This morning, we're very excited to welcome Dr. Vivek Reddy. Dr. Reddy received his medical degree at the University of Michigan, after which he completed residency at Yale and fellowships in cardiology and electrophysiology at Yale and Massachusetts General. Before his time at Mount Sinai, Dr. Reddy was the director of cardiac electrophysiology at the University of Miami and the director of experimental electrophysiology laboratory at Massachusetts General. He's currently the Leona M. and Harry B. Helmsley Charitable Trust Professor of Medicine and Cardiac Electrophysiology and the Director of the Cardiac Arrhythmia Service at Mount Sinai. He's an internationally renowned researcher in cardiac arrhythmias and has led several multinational clinical trials, including SMASH-BT, the PREVAIL and PROTECT-AF trials, and also pioneered pulsed field ablation for atrial fibrillation by leading the first human clinical trial using this technique, and was the first person to ever implant a miniature leadless pacemaker, which he did here at Mount Sinai. A very warm welcome to Dr. Reddy.
Thank you very much, Dr. Levin. I'm going to share my slides here. And let's get going. Just give me 1 second while it shows up, and I'm going to change the display settings. Okay, so hopefully everyone can see my slides and can hear me okay? I'm assuming yes. Okay, so first of all, I just want to thank the invitation. Thank for the invitation to present at the Medicine Grand Rounds. And what my charge today is to discuss device therapy in heart failure. This is a relatively broad subject. I'm going to try to touch on some of the areas that I think are very interesting and hopefully, hopefully you'll find interesting. Now, before getting started, please note that I have many disclosures, some of which are with devices that are generated by companies that I'll be discussing today. But probably most importantly, I will be discussing some investigational devices that do not have FDA approval, and I'll indicate that when we get to those points. Just by way of background, heart failure is a big problem. If we look at the overall prevalence, it's about 6 million people in the United States, about 1 million total in terms of incidence, and the mortality is substantial. If you look at the 5-year mortality, it's about 50%. So this is not a small number. It also has a significant impact in terms of global expenditures. The cost is thought to be about $31 billion, and it's one of the leading causes of hospitalization in the United States as well as outside the United States. It's also important that a large number of eligible patients are not receiving some of the evidence-based guideline recommended therapies. I'm going to briefly go over that before going into some of the newer therapies. And probably most importantly is even when conventional therapy is used, patients still remain at significant risk for disease progression and adverse outcome and hospitalization. Let's just take a look at how heart failure affects patients. This is looking at median survival stratified by age. So if you look along the x-axis here, these are groups of patients grouped by 5 years. In blue would be the expected life expectancy of a patient in the United States with an index age between, for example, 65 to 69. In contrast, look at the patients with heart failure. And here they're separated in 3 groups: those with reduced ejection fractions, those that are sort of the mid-range ejection fraction, and those with preserved left ventricular ejection fraction. The point is, regardless of the ejection fraction, and as a function of any of these ages, patients with heart failure have reduced survival. What are the therapies? So before getting the device, I just want to talk about some of the medical therapies. And it's important to talk about for a number of reasons. One is that they work. These are various agents, ACE inhibitors, ARNIs. So this is, ARNIs are angiotensin receptor blockers plus inhibitors of Sacubitril, which inhibits neprilysin. And what you notice is a relative reduction in mortality. And if you look at the number needed to treat for mortality, and this is standardized to 36 months, what you see is that the N is actually not terribly high for any of these agents. Probably best for beta blockers and aldosterone antagonists. And again, by the way, I'm talking about heart failure with reduced ejection fraction. So you see under 10 patients, you can eliminate 1 death at 36 months. Hydralazine, the nitrate inhibitors in self-identified African Americans is quite effective. ACE inhibitors and ARBs have been quite effective, but now we know that the ARNIs, that is the combination of angiotensin receptor blocker and the neprilysin inhibitor, the Sacubitril-valsartan, is actually better than ACE inhibitors or ARBs. So in patients that can take ARNIs, which is, as it turns out, most patients, it is most appropriate. And most recently are the SGLT2 inhibitors. And it turns out while these drugs were designed to treat diabetes by losing glucose and diuresis and et cetera, these inhibitors also seem to have favorable effects both from a hemodynamic perspective and the effect on the hormonal system. In addition to these reductions in mortality, there's also reductions in heart failure hospitalizations that are significant. I just want to point this out also. This is the CHAMP-HF registry, which was conducted between 2016 and 2018. And this looked at over 1,000 patients who, well, actually it looked at 3,000 patients at 150 primary care and cardiology practices. And if you look at the type of patients that they were, you can see the mean ejection fraction was reduced at 30%. Most were functional class 2 or class 3. And you can see the baseline blood pressure, systolic of 120, diastolic of 70. So these are patients you would think would be eligible for these agents. But here's what was actually seen, and these are the various agents. Now, most patients did receive either an ACE inhibitor, ARB, and beta blocker. So if we look at beta blockers, it was 67%, and ACE inhibitors, ARBs, it was 60%. Again, not at the 80 to 90% we'd expect, but still not unreasonable. If you look at angiotensin, if you look at the ARNIs, it was only 13%. And if you look at mineralocorticoid receptor antagonists, it was only 33%, right here, 33%. And SGLT inhibitors were infrequently used, but of course, these trials are just being performed. When medications were prescribed, few patients were actually receiving the target doses of these agents, the ACE inhibitors, the ARNIs, or the beta blockers. So, and finally, if you ask the question, among patients that were eligible for all class of medications, who received ACE inhibitors, ARB, ARNI, and a beta blocker, and mineralocorticoid receptor antagonist, it was only 1%. So the point of this slide is that in heart failure patients, we're not doing a great job of treating them with medications. So that's probably the first important point. But moving on, there are also devices, and two that are probably well appreciated by this audience are defibrillators and cardiac resynchronization therapy. So I just want to spend a few minutes talking about those. So when we think about defibrillators, these are devices that don't necessarily improve heart failure per se, but they do improve mortality. And in patients who are at high risk for sudden death, these heart failure patients. So initially there were the secondary prevention trials, AVID, CASH, and SIDS, and all of these decreased mortality substantially between 20 to 37%. And these are quite consistent along these various trials. And this was true whether the substrate was post-MI patients or dilated cardiomyopathy patients. And defibrillators have now become ubiquitous in their utilization, partly because their relative ease of implantation and safety of implantation. Here's just an example of a standard transvenous device. This is the generator that's in the prepectoral region, and this wire that you can see was advanced through the subclavian vein into the right ventricle. After that, there were the primary prevention trials, MATE-2, which looked at patients who had a previous MI and low ejection fraction, and the defibrillator patients fared better than the conventional group patients with an absolute mortality reduction of about 5%, 5.6%. And then there was SCUD-HF, which extended this further beyond post-MI patients to all heart failure patients. And compared to the control group, this is the placebo, had a 5-year mortality of 36%. The amio group fared no different. So even though amio is known to decrease mortality, some of the other toxic effects of amio seem to cancel this out. So the overall mortality was unchanged. But defibrillators significantly decreased the mortality by about 30%. So based on this, ICDs have become now quite prevalent in their utilization for patients who either survived cardiac arrest or who have low ejection fraction. But the other interesting point was that investigators appreciated that as patients get older, the mode of death changes. I'm sorry, not older. As they get worse heart failure, the mode of death changes. So if you look at the functional class 2 patients, for example, the majority of the deaths are sudden deaths, mainly arrhythmic deaths. And it's a minority that are related to heart failure. But as you get to class 3 and class 4 patients, the heart failure related mortality increases substantially. And it's partly because of this that CRT developed. And the other major observation was that as the QRS widens, mortality increases. So this is the Vesnerenone study. And what you see is in patients who have a reduced ejection fraction, compared to patients who have a normal QRS, those who have a wider QRS have worse mortality. And this is in a sense a dose-dependent phenomena. That is, the greater the width of the QRS, the greater the mortality. And this prompted the development of cardiac resynchronization. So just briefly, what is cardiac resynchronization? I think most of you know this already, but just very briefly, the idea is to resynchronize the heart so that instead of conduction with the left bundle where the septum is activated and then you have cell-to-cell conduction and eventual activation of the lateral wall, instead of that, to put a lead also in the coronary sinus, that is to snake it into the right atrium, through the coronary sinus, to one of the ventricular branches, so that one is pacing the epicardial surface of the left ventricle. So by pacing both the right ventricle and the epicardial surface of the left ventricle, we can resynchronize. I'm sorry, unfortunately, this video is not playing, but the point is, by putting these two leads, you can pace the heart to give a more narrow QRS and a more natural activation of the left ventricle. And this clearly has improved outcomes. So there were a number of clinical trials. I'm not going to go through them in detail in the interest of time, but what is important is that CRT, cardiac resynchronization therapy, has proven to be an important heart failure therapy that decreases all-cause, heart failure-related, and arrhythmic death, as well as heart failure hospitalization. And this is based on multiple clinical trials, including over 10,000 patients. We could look, for example, at one of the earliest trials, the companion trial, which compared patients who had class 3 or class 4 heart failure and compared either CRT-D versus CRT-P versus optimal medical therapy. So optimal medical therapy is, well, that's well appreciated. CRT-P is cardiac resynchronization, that is just pacing, and CRT-D is pacing with a defibrillator. And what was shown was the CRT-D did better than CRT-P, which in turn did better than optimal medical therapy. The HF trial looked at, again, took out the defibrillator issue and compared CRT, that is pure resynchronization, versus optimal medical therapy alone, and again showed improvements in outcomes, including all-cause mortality as well as heart failure hospitalization. And then some of the more recent trials, mated CRT and some of the others, RAFT and reverse, showed that even patients with earlier class heart failure, if one has a wide QRS, resynchronization improves all-cause mortality as well as heart failure. So, and the CRT has continued to evolve. This is from a recent data from a single center experience of almost 1,500 de novo or upgrade procedures for cardiac resynchronization therapy. And fundamentally, what was shown is that the procedure is quite successful. The implant success was 97% in the full cohort, including, again, 947 de novo procedures versus upgrade, that is patients who had a pre-existing either pacemaker or defibrillator that was upgraded to a CRT device. If one looks at the complication rate, there are complications, but most of these are relatively minor. So, and the overall complication rate is still on the order of a couple of %. And these requiring reprocedures is only on the order of 1 to 2%. Now, of course, CRT is not perfect. It does have some limitations. Importantly, not all patients respond to reverse remodeling. If we look at mated CRT, for example, which looked again at heart failure patients, class 1 or class 2 with a low ejection fraction, what was seen is those patients that had a left bundle were the ones who benefited the most. If one didn't have a left bundle, then there may have been a benefit, maybe in the patients who had interventricular conduction delay, but definitely not in the patients that had right bundle. So clearly left bundle branch block seems to be the most important. And it does matter. Those that are the super responders do much better in terms of heart failure hospitalization or mortality compared to those patients that are the so-called non-responders. And the non-responder rate has sort of stayed sort of consistent in the various trials that have been performed, somewhere between 25 and 30%. One of the important factors is that QRS width seems to directly correlate with response. So this is from, I believe, the reverse trial, though again, there have been a number of other trials that show similar data that as the QRS widens, there is a better response to cardiac resynchronization therapy. It's also interesting, by the way, that women respond even with a narrower QRS width compared to men. So how do we optimize CRT response? Well, this is jumping around, but first we want to make sure that the right patient is referred. We want patients who have left bundle branch block, and the wider the left bundle, particularly if the bundle is greater than 150 milliseconds, those are the patients that seem to respond the best. We want to maximize or optimize, I should say, the lead position. Better to be more basal than apical, better more lateral than anterior. But there is some limitation based on the coronary sinus anatomy. Because since we're using the coronary sinus anatomy, if it doesn't go to a particular location, then one cannot use this approach. And finally, we want to assure that we have a high degree of bi-beat pacing. Resynchronization only works if we're pacing all of the time. And there are instances where this may not be the case. For example, if the patient has atrial fibrillation and is conducting, and that preempts CS pacing, then of course CS pacing would not be beneficial. There are also certain patients who have frequent PVCs, and it's been shown that if one has a high PVC burden, eliminating those PVCs, whether it's with drugs or catheter ablation, actually does improve outcomes in terms of ejection fraction because of increased biventricular pacing. So what's the future? Well, there's a fair amount of work now being performed and looking at other ways to achieve resynchronization. That is, instead of pacing the coronary sinus, perhaps to pace the conduction system directly. Now, in some sense, one could argue, well, how could this be? If you have a left bundle branch block, why would pacing the conduction system high up allow you to resynchronize and get normal electrical conduction? Well, it turns out that most of the time, the majority of the patients with left bundle branch block, the location of the block is actually high up in the Purkinje system. But there are some issues with this, with either His bundle or left bundle branch placing. There is a significant learning curve. Electrical thresholds remain a concern. So if the pacing threshold increases, and suddenly that lead may no longer pace and the lead may have to be revised, which is another procedure. The tools that are currently being used were not designed for this application, and better tools are required. But probably most importantly, we need large randomized trials, because many of the early randomized trials looking at, for example, His bundle pacing have failed to show an improvement in outcome. I don't want to spend too much time on this, but two important points. So if we look at His bundle pacing, the idea is to put the lead directly at the His bundle in the right ventricle. It's technically challenging because it's a narrow target zone. This is fibrous tissue that's through which the His Purkinje cells go through. There's low success if patients have AV block. And unfortunately, His bundle pacing over time has a significant incidence of increasing thresholds. So even at the time of implantation, even if one has a good pacing threshold, over time that can increase to a point where battery life gets decreased for the device. So the field is actually moving away from His bundle more toward so-called left bundle branch area pacing. So in left bundle branch area pacing, instead of pacing the His, the idea is to pace further down in the septum, but not at the right ventricular septum, but actually to burrow the lead, as you can see here, into the interventricular septum so that the tip of the lead, the pacing portion, actually reaches all the way to the LV endocardium. So in essence, what one is doing is to actually pace the left ventricular or the left bundle Purkinje system. This has certain advantages. it's, oh, I'm sorry. Okay, it's technically less challenging because it is a wider area. You have dense muscle, and probably most importantly, the pacing thresholds with left bundle branch area pacing do not seem to increase with time, as has been seen with his bundle pacing. So this is an area that there's a lot of interest in, that we're seeing more and more activity in, and may improve our outcomes further. I wanted to also talk about one other interesting aspect. This is a potential device that might be used in the future. This device, by the way, is not FDA approved. This is a part of a pivotal clinical trial that I'll go over. So the idea here is leadless endocardial left ventricular pacing. So there's several components. One is a standard either pacemaker or defibrillator with leads in the right side of the heart. Then there's a receiver electrode that's implanted directly in the left ventricle, in the lateral left ventricle. Then there's a battery connected to the transmitter. So the way this works is the battery powers this ultrasound transmitter. The ultrasound transmitter, emits ultrasound impulses, which are detected by the receiver electrode, and that ultrasound impulse gets transduced into electrical impulse to pace the left ventricle. So just to go through this quickly, the idea is the device will detect the standard pacing of the right ventricular lead of the standard device. Then within a few milliseconds, it locates the device to find the best location, and then it transmits a high energy ultrasound impulse, which then gets transmitted, which gets converted to an electrical impulse. And this all happens within a few milliseconds, so that you pace the left ventricle in time with the right ventricle. How does this work? So how does this little receiver electrode get placed? Well, here's an example, one of our cases. We have this deflectable sheath that's advanced into the left ventricle. Then we advance the receiver electrode inside. We push this up against the wall. We can inject contrast or look at ultrasound to see where the catheter is relative to the wall. And then we extrude the device slowly into the myocardium so that the tip with these tines engage the wall, and then it's deployed. And because of the small size of this device and the fabric, it gets endothelialized very quickly. And then that's the device. We studied this in a first-in-human clinical trial. And what we showed was that we have significant improvements in ejection fraction, with 2/3 of the patients showing at least 5-point improvement in ejection fraction. And here in the continuous variable, you see about a 7% increase in ejection fraction. And these are all patients, by the way, who either failed or did not respond to standard CRT. If we look at, also there were improvements in functional class, with 2/3 of the patients showing at least one functional class improvement, and at least half the patients showing at least a 15% improvement in the left ventricle end systolic volume. So here you see the end systolic and, end diastolic and end systolic volumes at baseline versus the 6 months, both improving. Now that's a non-randomized study. So based on this, there's a large multi-center prospective pivotal IDE that is ongoing called the SOLVE CRT trial that's is enrolling 350 patients at 45 centers. It's a double-blind trial where all patients receive the system and they get randomized to either sensing or pacing. And it's looking at patients who are either non-responders or untreatable patients. And again, this is an ongoing pivotal trial. So hopefully once we have the results of this, we will have additional options. I just want to point out, this is the other idea is, since leadless pacers have become more common in patients who have chronic atrial fibrillation and ventricular dysfunction, one option that we now consider is to put a leadless pacemaker in the right ventricle, so that this system can detect the right ventricular pacing and then again emit the ultrasound impulse to pace the left ventricle. Again, this is an option. This is still being studied. Now I want to move away, in the rest of the time, I want to move away from heart failure with reduced ejection fraction to talk about the fact that many patients who have heart failure don't have reduced ejection fraction, but actually have more preserved ejection fraction. So this is an interesting slide that shows you the spectrum of the left ventricular ejection fraction in patients with heart failure. So on the x-axis, you see the ejection fraction, and on the y-axis, number of patients. So clearly those patients in the low end here are what we call HFrEF, meaning heart failure with reduced ejection fractions. Those on the upper end are the HFpEF, heart failure with preserved ejection fraction. Depending on where you draw the line, this heart failure group with preserved ejection fraction constitute a substantial percent of patients with heart failure. Somewhere between a third to actually about a half the patients have this so-called HFpEF. And these patients present very similarly. The HFrEF patients in yellow, the HFpEF here in red, they both present with edema or orthopnea, paroxysmal nocturnal dyspnea or rest dyspnea, crackles, JVP, though I should note that the HFpEF patients are less likely to present with cardiomegaly or an S3 GALLOP. And importantly, HFpEF is increasing in prevalence. So if you look at this, and if you look at this particular study, it's also increasing in both women as well as African Americans. So here, if you look at Black men here or Black women, you can see a substantial increase. HFpEF here is shown in blue, and you can see this increase, particularly in Black women, which is the most striking increase. So this is a problem, and it's an increasing problem with time. Now, I should note so what can we do in terms of treatment of heart failure patients with preserved ejection fraction? Well, overall, the trials have been somewhat disappointing. Other than beta blockers, there is no single prospective randomized trial that has definitively shown an improvement in outcomes in HFpEF. Having said that, recently the FDA approved the use of Sacubitril-valsartan to treat patients with HFpEF. And I just want to go through that really briefly before getting to the novel devices. So if we look at Sacubitril-valsartan, what is it? Well, valsartan, this is an angiotensin receptor blocker, and it works on the renin angiotensin aldosterone system. And this is the same, and again, it affects the system to attenuate the increase in vasoconstriction, sympathetic tone, aldosterone levels, fibrosis, hypertrophy that occur as a result of this cascade. Now, this combination, in addition to valsartan, it also includes this neprilysin inhibitor, sacubitril. So sacubitril, what it does is it works on the neprilysin pathway. Neprilysin is an enzyme that breaks down some of these vasoactive peptides, ANP, BNP, bradykinin, et cetera. And by breaking these down, by inhibiting the breakdown of these, this is thought to allow decrease in blood pressure, sympathetic tone, aldosterone levels, as well as decrease in fibrosis and hypertrophy, as well as improvements in natriuresis/diuresis. So the question was, and we know that the sacubitril-valsartan is effective in HFrEF patients. So an important question was, could this be also effective in HFpEF patients? And there was a trial called Paradigm HF. Paradigm HF was a trial that looked in HFrEF patients, and it was strikingly positive. It was published in 2004 in the New England Journal of Medicine, or 2014, and compared to ACE inhibitor alone, the combination showed improvements in the primary endpoint of cardiovascular death or heart failure hospitalization, as well as the individual components of cardiovascular death, as well as all-cause mortality. And not shown here was also improvements in heart failure hospitalization. This was also studied in HFpEF patients in a trial called Paragon HF, which was more recently published. Paragon HF looked in, again, HFpEF patients randomized to either valsartan or sacubitril-valsartan. And what was seen was actually not a significant difference. So if you look at the primary endpoint of heart failure hospitalization and cardiovascular death, the p-value was 0.59. And this was not a robust result. It was not statistically significant. And in fact, if you look at the individual components, this difference was driven by heart failure hospitalization with no hint of difference in cardiovascular death. But having said that, when one looked at the data a little more carefully, and particularly if you look at this by EF quartiles, what was seen was in Paragon HF, those patients that had reduced ejection fraction, again, albeit not severely reduced, these patients seem to derive a greater benefit than those patients whose ejection fraction was the highest. And in fact, if you look at this and you plot this the relative benefit as a function of ejection fraction, what you see is as the ejection fraction gets lower, there seems to be a benefit. So this raised the possibility that those patients who have sort of HFmEF, let's call it, heart failure with sort of mid ejection fraction may actually derive some benefit from this pharmacotherapy. Based on this, the FDA recently expanded the indication, and it was a strikingly positive vote. Though having said that, I do have to note that the rest of the world doesn't necessarily agree with this decision. So this is somewhat, I guess, controversial decision. But basically what the FDA said was that sacubitril-valsartan is indicated to reduce the risk of cardiovascular death or hospitalization for heart failure in adult patients with chronic heart failure. And the benefits are most clearly evident in patients whose EF is below normal. They also note that EF is a variable measure, so use clinical judgment in deciding whom to treat. So at this point, when looking at patients who have HFpEF or HFmEF, certainly diuretics are important, as well as, of course, controlling things like blood pressure. Whether or not sacubitril-valsartan should be used is, at this point, I think, still up for debate. Now, at this point, I want to talk for the rest of the presentation about two novel device therapies that are being studied in this so-called HFpEF or HFmEF population. I think they're very interesting. One is actually an interatrial shunt device to relieve left atrial pressure, and the other is a catheter ablation device to alter sympathetic tone to the Splanchnic system. So let's first talk about the first. Now, when you think about HFpEF patients, there is a prognostic importance to increase left atrial pressure. So if you look at this graph, what you see is that with increased wedge pressure, that is left atrial pressure, there is, with increased wedge pressure, there's a decrease in terms of exercise capacity or 6-minute walk. Also importantly, those patients that have the highest wedge pressure, particularly work-corrected wedge pressure, that is exercise wedge, those patients have a much higher mortality compared to those patients whose wedge is not as high. If we look at HFpEF specifically, the hallmark appears to be elevation in left atrial pressure. Now, this is sort of classic work now by Barry Borlaug and his colleagues at the Mayo Clinic. And what they showed was that in sort of normal patients, if you do an exercise test, so the way you do this is there's a swan catheter is placed in order to look at the wedge pressure as well as other cardiac pressures. And then the patient rides a bike. So this is a bike that's affixed to the cath lab table. And what you can do is to actually measure the pressures. And in a patient who does not have HFpEF, sort of a normal patient, what you'll see is when the patient exercises, when you first go feet up and then exercises, 1 minute peak exercise and recovery, there's a relatively small increase in the left atrial pressure. In fact, there's a small increase in all the pressure. You see a right atrial pressure increases by 2 points, wedge by about 4 or 5 points, the pulmonary artery pressure by 10 points, and the pulmonary vascular resistance actually decreases. In HFpEF patients, what's seen is a significant increase in wedge pressure. So, and this is a nearly universal finding. So what you see when the patient puts their feet up, it increases somewhat, and with exercises, it increases substantially and finally comes down after recovery. And the other interesting thing is that the increase in wedge exceeds the increase in right atrial pressure. So if you look, for example, the right atrial pressure does increase by about 10 points, but the wedge here increases by almost 20 points. Pulmonary artery pressures do increase, but interestingly, the PVR actually ends up decreasing. So how can one take advantage of this? Well, there was an interesting clinical observation that was made actually decades ago, which is the observation that an atrial septal defect can be protective in patients who have rheumatic mitral stenosis. That is, in patients who have a congenital atrial septal defect, the symptoms of mitral stenosis are less profound. And this appears to be related to decompression of the high left atrial pressure that occurs in mitral stenosis. So in someone that has mitral stenosis and an intact septum, the left atrial pressures will increase and cause congestion, et cetera. But if one has a congenital ASD, atrial septal defect, then there's a decompression of the left atrium into the larger reservoir on the right side, the right atrium, the great veins, hepatic veins, etc. So based on this observation, the idea was, well, perhaps we could directly reduce the left atrial pressure in appropriate patients who have heart failure with preserved ejection fraction. So this is a device that's actually, there are several devices that are in clinical trials. This is the one that's furthest along, that's actually just near completion of their pivotal trial, we believe. So it's a stent-like device that's placed in the intraatrial septum to actually create a hole and then keep that hole open. And the idea is to allow dynamic decompression of the overloaded left atrium by shunting this blood into the right atrium. It's advanced through a catheter, and here you see the example as the device is extruded by withdrawing this outer sheath. The implant is 8 millimeters in diameter, so that's the inner diameter, so the hole will ultimately be 8 millimeters in diameter. And here's just an example using X-ray and either ultrasound, transesophageal echo, or ICE guidance. So here on the left atrial legs are deployed in the left atrium, and then once this is withdrawn completely, the device is hence fully deployed. Why 8 millimeters? Well, this is work from Dan Burkhoff and his colleagues. They used simulation data from looking at real exercise hemodynamic data from heart failure patients with preserved ejection fraction. And what they show is that, at baseline, of course, left atrial pressures are elevated, more so than right atrial pressures. And if you create a shunt, then the left atrial pressures will fall and right atrial pressures will increase marginally. What he showed was that as you increase the size of the shunt, there's a point where the drop in left atrial pressure becomes equalized the benefit is no longer seen. So at 8 millimeters, that's where you see the greatest drop in left atrial pressures with minimal rise here in blue of the right atrial pressures. So that was the experimental, the hypothetical basis for this 8 millimeter diameter. Here are the clinical studies looking at this intraatrial shunt device technology. So initially there was a pilot study that we were involved with. It was a non-randomized study, single arm, showing the feasibility of this in patients with heart failure with preserved ejection fraction. Then there was a non-randomized CE mark study, single arm study, 64 patients. Then there was a randomized sham-controlled trial conducted in the United States, 44 patients. And finally, the pivotal trial, which is actually ongoing. It's actually completed enrollment about a year and a half ago, and now we're in the follow-up phase, and we should have the results in the not too distant future. Let's just take a look at the data really quickly. This is the multi-center non-randomized European study looking at patients who had preserved ejection fraction, who had heart failure, and an elevated wedge, either greater than 15 at rest or greater than 25 with bicycle exercise. And what was seen was that compared to baseline, after placing the shunt, there was improvements in exercise time, both at 6 months and at 12 months. And there was a decrease in the wedge pressure, both at 6 and 12 months, as well as a decrease in the work indexed wedge pressure. So all of these look favorable. Again, though, non-randomized study. This was followed by a sham-controlled randomized trial called reduced LAP1, where patients were randomized in a sham-controlled fashion, again, preserved ejection fraction patients who had elevated wedge pressures and elevated BNP or pro-BNP or hospitalization. And they were randomized, again, in a sham-controlled fashion to either implantation of the device or just the right heart cath. And here's what the data shows. So in the control group, baseline is in red, blue is the 30-day invasive right heart cath data, and you see basically no change in the wedge. In contrast, in those patients that received the device, there were significant improvements at 30 days in terms of both the baseline wedge pressure as well as with exercise. And again, this is the same data showing compared to control. If you had the intraatrial septal device, there was a greater fall in the exercise wedge pressure. And this occurred, by the way, without a significant increase in the pulmonary vascular resistance. In fact, it actually decreased. And I'll come back to that. These are the 1-year outcomes in this sham control randomized trial. Again, the N is very small, so one has to be careful how to interpret these data, but it is a randomized study. And if you look at the combination of major cardiac or renal adverse outcomes, the patients who received the shunt fared better than the sham control. Also, in terms of cumulative incidence of heart failure, those that received the shunt fared better than the sham control. Now, based on this, and then 3 other important questions. Is the shunt durable? Well, in all of these studies, there's been 100% shunt patency with left to right flow at 1 year and no instances of device thrombosis failure or retrieval. Is there an increase in stroke? After implantations, these patients get a baby aspirin indefinitely. And what was seen, and this is in the open label 64 patient study, there was only 1 stroke after 3 years of follow-up. And that stroke was not an embolic stroke. So because these patients have high left atrial pressure, there does not appear to be any significant right to left shunting. Finally, is there a risk for heart failure, for right ventricular failure, since you are shifting from right to left? Now, we should note that in these trials, we did not include patients who had right ventricular dysfunction. So having said that, what's been noted is that there is no significant worsening of the RV parameters. In fact, RV rejection fraction here actually seemed to improve a little bit. And certainly there was no significant increase in RA pressures or RV pressures. How can that be? Well, part of it may have to do with improved oxygenation. So because of the shunt, there's increased venous O2, and that actually may improve vascular recruitment and actually end up with decreasing pulmonary vascular resistance and no significant worsening of right ventricular pressure. So at least that's what's been seen so far. Based on this, again, the pivotal trial is ongoing. 608 patients have been randomized already. So now we're in the follow-up phase, and we should be able to hopefully see the outcome within the next 6 months to a year. Finally, I want to talk about, I think, a really interesting way of thinking about this, which is, sorry, I'm going to hide this, which is a different way to think about congestion and fluid overload. Normally, when we think about heart failure, we think about this, the sort of the congested heart, elevated neck veins, pitting edema, and certainly congestions you see on this chest x-ray. And certainly this is true in patients who have significant decompensated heart failure. But it's interesting that there's another way that maybe we should be thinking about this that's challenging this paradigm. And there are a couple of observations that inform this. The first is that if you look at patients who get admitted with heart failure, if you look at weight gain of greater than 2 pounds, and this is control versus the cases, what you see is that the weight gain happens within about 2 weeks or so. Okay, so it's relatively recent, 1 to 2 week weight gain. However, if you look at the pulmonary artery pressures, there's an increase in pressure that happens starting almost 4 weeks before. So the question is, how do we reconcile this? How can there be an increase in pulmonary pressures and filling pressures, even on the left side, that occurs before there's an overall increase in weight or fluid status of the patient? And part of the answer may be here. This is a very interesting study where these investigators took 20 patients and they basically brought the patients into the clinical study, and they admitted the patients over the course of a couple of days, 48 hours. And what they did was, first they experimentally withdrew all the heart failure medications for 48 hours, all diuretics and neurohormonal blockers. This is 20 patients. What was seen was what was expected. There was an increase in symptoms. There was an increase in BNP from baseline of 960 to 1883. And there was an increase in systolic blood pressure from 131 to 152. There was also an increase in left atrial volume based on echo from a 21% increase. And there was an increase in thoracic impedance, suggesting, a decrease in thoracic impedance, suggesting a volume increase. However, this occurred without a change in body weight. So the question is, how is it possible? How can you have such an increase in congestion without an increase in actual fluid status? And it may be that it may have to do with actually shifting of volumes. So if we go back to Barry Borlaug's exercise study, looking at patients with HFpEF versus controls. When you first put the feet up, you have an increase in the wedge, and this is going to be volume redistribution, and that's no big surprise. But the question is, how do you get this additional increase with additional exercise? What is the mechanism of this? And it turns out that the mechanism appears to be related to splanchnic nerve traffic and increase in sympathetic tone in the splanchnic vascular compartment. So the splanchnic system, which of course the spleen, the liver, the intestines, together this includes almost 30 to 40% of total body volume, intravascular volume. And with an increase in sympathetic tone, then you can, and these vessels are highly innervated. So with an increase in sympathetic tone, there is a central redistribution of this volume. So again, this just shows the portal system, includes the liver, the spleen, the kidneys, the intestines, etc. So the concept is, it may be that in patients who have the volume distribution related not necessarily to increase overall volume, but because of redistribution from the abdominal compartment to the central compartment, that may be the initial sort of manifestation or initial cause of worsening of heart failure with preserved ejection fraction. And it's based on this, the idea of modulating sympathetic tone by modulating the splanchnic nerve. So how could this be done? Let me just talk about this. So remember that the splanchnic nerve comes from the sympathetic chain, and there's one on the right side and one on the left side. They come together to form the greater splanchnic nerve, which then go to the celiac plexus, and from there innervate the various vasculature. So there are a couple of really interesting acute and chronic studies that were done that suggest that this might actually be an important target. So this was a study that Marat Fudim at Duke performed, actually a series of studies. First was an acute canine study where they showed that if they stimulated the celiac plexus, and these are areas of stimulation, nerve stimulation, you end up getting increases in central venous pressure as well as pulmonary artery pressure. So you have this sort of central redistribution with stimulation. Then they did the same study in healthy volunteers. This was done by an epidural, first was an epidural block, and then there was stimulation performed. And again, you see this sort of increase in right atrial pressures. This is then a case report that we published in a patient who had heart failure with preserved ejection fraction. Here, instead of doing this surgically, we took a catheter, put it through the azygos vein, so up the right atrium to the azygos vein, down the azygos vein into one of the intercostal branches, and stimulated from this catheter the greatest splanchnic nerve. And what we saw is that with stimulation, which you see here, you see an increase in central venous pressure, an increase in left atrial pressure, with really a relatively small increase in heart rate. So the elevation of the pressure is elevated long after the end of the stimulation because of the central redistribution. So this seems to recapitulate the concept that by stimulating the greatest splanchnic nerve, we can increase central pressures. So based on this, how could we use this to treat patients? Well, this is a series of studies. So the first is by Marat Fudim, who looked in this so-called Splanchnic HF trial, which is an acute human study in patients with decompensated heart failure. So patients came in and then they did the splanchnic nerve block. And the way they did this is with fluoroscopic guidance, the anesthesiologist would use a needle to basically inject lidocaine to this region of the greatest splanchnic nerve and celiac plexus. And they treated only 13 patients, but it was a very interesting study. And what they saw was that when you block this, there's a decrease in mean arterial pressure and an increase in cardiac index. Again, these are patients with acute decompensated heart failure. Then they extended this in the Splanchnic HF2 trial to patients with chronic heart failure. And what was seen, here you see the exercise test. Actually, let's look at the wedge pressure. So at baseline and with exercise, you see an increase in the wedge pressure, then comes back down with recovery. If you perform this transient splanchnic blockade, then you have a decrease in the left atrial pressure, and the increase is attenuated compared to baseline. And here you see again the actual numbers. If we just look at the 6-minute walk, for example, there was significant improvements. Again, small numbers of patients, but overall seemed to improve both hemodynamics as well as exercise function. What's the mechanism of this? Well, this is an interesting study where they looked at, based on thoracic impedance, they could look at thoracic fluid. And what was seen compared to pre, if you look at post, what you see is that the thoracic fluid content increases. So with, this was with ablation. So with ablation, the thoracic fluid actually decreases. There was more abdominal. So again, a volume redistribution. Can this work long term? Well, this is a porcine study. Interest of time, I'm going to go through this quickly. But what was seen, this is an animal model, a porcine model of heart failure with preserved ejection fraction. And what you see at baseline, at 10 weeks, and at 20 weeks, you see increases in the blood pressure, as well as increase in left atrial pressure in this model. But at 10 weeks, if you then do splanchnic denervation, you see an attenuation of the blood pressure and an attenuation of the wedge pressure. And I won't go through this in detail, but this is also consistent improvements in neurohormonal indices, as well as LV mass and left atrial volume. So the idea is that splanchnic nerve blockade seems to have a consistent and durable effect. So based on this, there was a first-in-human study. This was using a surgical approach. So this was an approach where this was a video-assisted thoracoscopic procedure. So you can see here on this picture, the right lung is dropped, and the surgeons went in and they basically resected the greatest splanchnic nerve, or a piece of the greatest splanchnic nerve. By the way, this is a procedure that is actually used now in patients who have cancer pain. So the procedure itself is a technique that has been used. Here's what was seen. Again, this is a 10-patient study in patients who had heart failure with preserved ejection fraction. And what was seen compared to baseline, which is shown in red, and here again, we can look at the wedge here. Compared to baseline, what was seen is an improvement in all the pressures. So compared to baseline in red, after splanchnic nerve blockade, all the pressures drop, and the increase with exercise is attenuated compared again to control. And this was seen at the 1 month, at 3 month, and even at 12 month. This is the clinical outcomes. You can see the functional class seemed to improve from all class 3 to mainly class 2 or class 1. This is symptom score improved and exercise duration improved. Now that's a surgical study. How can we do this percutaneously? So this is the technique that's being studied. So the idea is to take this catheter, introduce this again into the azygos, into one of the intercostal vein branches where the greatest splanchnic nerve crosses, and then deliver radiofrequency energy to ablate this particular nerve. So I'm just going to go through this quick video. So this is the actual catheter itself. It's an over-the-wire catheter. So the idea is that we go up through the vein, go put a sheath into the azygos vein, then through this, advance the wire, and then advance the catheter. And then once we position this at the location of the greatest splanchnic nerve to deliver energy to ablate the greatest splanchnic nerve. Again, only one of the greatest splanchnic nerves are ablated, only the one on the right side, not the one on the left side. So this was used in a first-in-human trial in Europe, where 11 patients who had heart failure preserved ejection fraction underwent the procedure. Importantly, there were no device-related serious adverse events. There were no device-related serious adverse events. And as compared to baseline, the patients did indeed seem to show, again, improvements in the hemodynamics as well as symptoms. But again, this is a non-randomized study. So based on this, the Rebalance HF trial is ongoing here in the United States, and it's Sinai actually, where this is a prospective, multi-center randomized sham-controlled double-blind trial where both the patient and the cardiologist who's taking care of the patient are blinded to the treatment assignment, though the interventionalist who does the procedure is not blinded. So the plan is to treat 80 subjects, and we're just, I think, about 10 or 15 subjects in. So patients get randomized to either treatment or sham control. Patients who qualify are are screened by the screening committee to make sure that they're being managed optimally in terms of medications. And of course, and then there's the echo and invasive hemodynamic core lab. The inclusion criteria, again, are patients who have heart failure requiring current treatment with diuretics for at least 30 days. They have class 2 or class 3 heart failure or ambulatory class 4 heart failure, and at least one of the following, either heart failure admission, treatment with diuresis in the past year, or elevated BNP or pro-BNP levels. Ejection fraction should be preserved, and the wedge should be elevated based on the exercise ergometry. So patients that qualify will receive a right heart cath, and if they qualify, then they either undergo the ablation or the procedure is stopped if they're sham control. Again, the procedure is to target the right greatest splanchnic nerve, and we do this with either under general anesthesia or moderate sedation. And the patients again get randomized to either ablation or the sham control, and then the patients are managed post-procedure by the blinded heart failure cardiologist. So with that, it looks like I've run out of time, which is good because I think I've run out of slides. But I think what I really want to show is that device therapy for heart failure is really being studied in, I think, careful randomized trials, and particularly for heart failure with preserved ejection fraction, those patients that that we see that we don't have other medical options. These are patients where I think both of these therapies, while they're not yet FDA approved, certainly they can be offered to our patients as part of clinical trials. Thank you very much.
Great, thank you, Vivek. Thank you, Dr. Reddy. And there's already some comments, questions in the chat. We're running a little bit late, but we could do those.
Okay, should I just go through them, or?
Sure, that's fine.
Okay, yeah. So if a small RTC does not show benefit, but a small RTC doesn't, would it not imply that the number needed to treat should be significantly larger? I think the question was written wrong. Yeah, okay, large RCT. Okay, if a large RCT does not show benefit, but I mean, the answer is yes. I'm not sure exactly what this question was referring to, but absolutely. Maybe Dr. Greenberg, if you could explain what you were specifically referring to, because I think, but in general, I agree with your point. I mean, if the smaller RTC shows a trend but not a benefit, and the other one shows a statistically significant benefit, then yes, you've proven the benefit. Now, whether or not it's significantly larger has to do with obviously the magnitude of the benefit, and also has to do with well, the magnitude of the benefit. And then the third point, of course, is whether or not it's clinically significant. So there's absolute changes in benefit, and then relative changes in benefit. So based on the baseline event rate in the control group, then that also has an impact. So certainly, I think as a general comment, that's true. Does the procedure change nuclear image? That's a very interesting question. So, you know, there is some data. Some of the medical therapies can affect favorably sympathetic tone. So if you do, for example, MIBG imaging, you might see something favorable in terms of cardiac imaging. But beyond that, I don't think anything has really been studied, certainly for these procedures. What's the potential for infection of the leadless pacemaker device, and infected, more difficult to remove than leads? Yeah. So interestingly, there have been a number of different leadless pacemakers that have been used. So we have FDA-approved single-chamber right-side leadless pacemakers that we've been using now as regular clinical practice. And it's actually really rare to see an infected leadless pacemaker. I'm not saying it can't happen, but I've never seen one in all the clinical trials, including thousands of patients. We've yet to see one. So I'm sure that somebody has published a case report somewhere, but we've not seen it. Would it be difficult to remove? Part of it depends on the device. So there are two different devices. One, which is a little bit longer, has a back end that was designed to grab onto it to remove it. The other one, which is a little smaller, you can also remove that, but only if it's early after the procedure, like within the first year or two. Once you get beyond that, it just gets covered with endothelium and tissue, and then you can't really access it.
That looks like, is there any more questions? I don't know. We're at 9:30. I think maybe we can thank you, Dr. Reddy, for a really nice comprehensive review, including the medications and all the devices. It's really great to see you all in one place. So thank you very much for presenting today. Really appreciate it.
Thanks for the opportunity.
Yeah, absolutely. Have a good day, everybody. Stay cool out there.